going to be moving forward with our presentation today, which is immediate dentures using a digital workflow. Really excited for this one. I know that personally, as the product manager of Simplus for Orem, we get a lot of questions on this. So really excited to go through this with Dr. Bertsch. And just some housekeeping. If everyone does have any issues with their Zoom link or anything like that, feel free to contact Tanya S at oremgroup.com and she can assist you in any way. And without further ado, I'll hand it off to Dr. Bertsch.
Thank you so much, Daniel. So yeah, we are talking about immediate dentures today. This one I was most excited for because it was probably my favorite thing to do in dentistry. And reason being is I find it's like the transformations are incredible and they're instant. Like the patient walks in, like this guy just did his immediate, I think it was last week. And that's literally how he always looks. His eyes are closed like that. And I'm not sure why, but anyways, awesome guy, super friendly. And the day we were extracting his teeth, he was so excited he couldn't even sit in the chair. And I thought that he actually had taken something and didn't tell me. And he was like so apologetic. He's like, I've been waiting for this for not my whole life, but like a long time. And so he's like, years and years and years, I'm so excited to get rid of these teeth. I've had so many issues with them and I can't wait for my dentures. So that was he didn't realize he had to come back for 24 hours. So he ended up coming back 48 hours, but that's his post-op pick 48 hours after. And it's crazy the difference. And he was telling me one of his buddies, everybody was really happy with the dentures. And one of his buddies was like, man, it looks like, I feel like we're 15 years back drinking in your garage at the farm. He's like, that's what your teeth look like. He's like, it's insane. So he was so happy, had really good feedback. So that's what today is all about. I'm going to talk about a bunch of my patients that we have amazing stories with and some that have been issues and things we've had to work through. So hopefully if this happens to you, guys can take what I've learned. But at the end of the day, his smile, all it was a scan and a couple of photos, and the lab created what we see there on the bottom in the orange jumper. So anyways, today we'll talk about immediate dentures. Oh, there we go. So yeah, in the spring series, number 3, we have one more left, denture relines. I feel like it's like summer's coming. Well, it's here today. It's like plus 27. And we're getting ready to just take some time off and rest. So today's webinar, we're going to talk about the definition, go over advantages, benefits, tips for scanning, establishing a vertical, aesthetics, staging treatment planning, setting patient expectations, which I'm always huge about, especially with immediate dentures. That guy that I showed you at the beginning was a massive success story, but they all aren't. And it really depends on the quality of their bone, their periodontal status going into it. And they need to be aware of kind of what they can expect from their experience. So everyone's different, and I always tailor that conversation. So that post-operative instructions and cases, post-operative instructions, I have a sheet that we give patients, and I know I was a little tardy in not getting the consent form that a lot of people asked for. There's some staffing changes and whatnot. So I'll send both to Daniel, and then he can send them out today so that you guys have both the consent form and the immediate denture post-op instructions. And again, I apologize for that. So immediate versus complete. So immediate dentures where the patient comes in, we extract the remaining teeth and place the denture right away. Complete dentures, all the teeth are extracted, the patient heals for roughly 3 months, and then the denture is made. I actually never do the complete denture except once, and it was where the patient has such severe tori, like they were lingual tori that were touching, and so we sent him to the oral surgeons. They extracted his teeth, they removed his tori, and now we're making his denture. But otherwise, I try and avoid it like the plague. Reason being is that the patients that have come to me who have had that done where all their teeth are extracted and then we're making a denture after, they've gone from having their teeth to having no teeth, and they've had to function and learn how to eat and everything for talk, chew for 3 months. And now you put these 2 massive hockey pucks, that's all the analogy I always use, in their mouth, and now they need to learn to function again. So it's like another learning curve. They just went through a learning curve. I feel like it's a lot for patients, and those are the patients that I often have the most adjustments, the most problems with, in the sense of like them getting used to their dentures. They don't wear them, so they don't get used to it. They'll come back and be like, they're just not comfortable, they're too big, they're too bulky. And it's like, that's how a denture needs to fit. They want me to cut into a horseshoe on the roof of their mouth so they can feel their palate. It's like, no, like unless you're getting implants and having that conversation. But so yeah, so steer away from complete dentures. I always try and do immediates, except in the case of large tori. And then this way the patient starts getting used to the denture right away. They're learning to talk, smile. And that's often the most exciting part, is they're excited for their new teeth, they're excited for the smile. So to get it and walk out with it, the day of the extractions, when they get their denture, they're never really excited to have it. But the next day, oftentimes they're excited and happy with their new smile. Like I said, for the most part, we'll go over a few cases, but otherwise it's just kind of like a limbo. So first I'll introduce this lady, and then we'll talk about the advantages of immediate dentures. So it's one of my patients from Kindersley. I absolutely love her. She booked an appointment under denture adjustment this like a week ago Tuesday, and it was to show me her wedding pictures, because we did her immediate denture. We timed it all out so it'd all be done. The reline would be done before her wedding, so she'd have her smile and her teeth comfortable for her wedding. So anyways, she brought her wedding pictures to show me, and it was just like literally in every wedding picture she's beaming, and she's like, I'm smiling so much, and I wouldn't have done this had I not had my denture and not gone through this, because her teeth previous, which I obviously don't have pictures of, sorry, were very terrible condition. So she was truly the blushing bride, and just like so excited. So like story like that is just like motivates me every day to do immediate denture. So that's her couple days after her wedding, and that's what she looked like in every picture, just beaming. And she wanted the diastema because her natural teeth had that. So that's the other thing, is I really try and keep the natural dentition in the denture as much as possible. So so advantages: immediate aesthetics and function. I've already kind of touched on that. Control bleeding. I always explain to patients it acts like a band-aid. So when you apply the pressure, it helps with the clotting and swelling. I'll get to this, but I always emphasize that if the denture comes out, put it back in right away, because the swelling can take over. And then it has happened a few times to me where I can't get the denture back in for several weeks, and I'm not about to adjust the heck out of it to make it even worse when the swelling does come down. So greater comfort, less trauma during healing, and the patient starts to get used to the denture right away, because they keep it in for the first 24 hours. Less adaptation required. Like I said, they don't have to learn to function without teeth, and then again with dentures. Vertical dimension is established, so that one has a few asterisks, because the beauty with the scanning, and I'll go through this, is that we can maintain their vertical, and then of course depending on how much they shrink and the changes in bone, we need to reestablish that. But it's a great jumping off point, so you're not starting from scratch, and they're not used to being sunken in and closed, and now you're opening them up and they're like, holy heck, what am I going to do with all this? So and then I find I end up compromising on vertical, because they're not used to being open so much. So that easy, nice transition, maintaining the vertical, is awesome. And then yeah, ability to use natural teeth. So those few patients that have come to me and their teeth have been out, I have no reference point. Oftentimes they don't smile in pictures, so you're just starting from absolute scratch. So the beauty of having their teeth and doing immediates is like this lady here, where we can replicate the size, the shape, the diastema, certain characteristics that they want, and having that in their final denture. So disadvantages: no opportunity for a try-in. Obviously you can't try the denture in, so it's bitten me in the tuchus a few times, but there's ways around that and ways to pivot, so it's not the end of the world. And so that's where I find sending pictures has been a huge benefit and a huge change, so for the better. And the fit is less accurate because of the changes. Like, I've had this happen where the denture goes in and it's really retentive. When you first extract the teeth, such a good fit, everyone's super excited. They come back a few weeks and it's already getting loose. And so then we're looking at doing denture adhesives and keeping it in that way. So sore spots can be quite uncomfortable. The reality is switching from digital dentures from the traditional way that I used to do them with Alginate and PBS and everything, is the sore spots have been cut down so much. I found when and maybe it was my technique and how I did it, but with the traditional way of doing dentures, I had a lot of patients come back and the borders would be overextended. They'd bite down and it's digging into my gums, they'd always say. So I'm relieving that. And as they heal, I found I was doing it constantly. So with the digital scan, I've never had overextension. It's almost impossible to get. The sore spots that I do experience now are in the canine area, and I believe it's from the bone, the buccal bone area there, and then the frenum. Sometimes the labial frenum isn't captured perfectly in the scan and then replicated in the denture. So that's a disadvantage, is the sore spots can really inhibit the patient's function and them eating right away. But at the end of the day, it's easy to adjust, and a quick adjustment goes a long way. And then they're able to start using the denture more. So performance of fit is lessened. So yeah, with this, so my solution to this is that I try and do 2-stage immediate dentures. So where I extract the posterior teeth, let them heal, and then have the scans done after they've healed for 6 to 8 weeks, depending on the case. And then at least at the posterior, we can get a seal. And then at the anterior there, as the teeth are extracting, everything shrinking, then we can, it's not the whole denture that's changing. So I really like doing 2-stage immediates and try and do them whenever I can. So tips for scanning, I always do a hygiene appointment. So generally I'll do the extractions of the posterior teeth. Depending on the buildup, I might do get the hygiene appointment before, and then get the hygiene appointment. And that's just to help get the inflammation down, help get the buildup down. Because at the end of the day, that's really going to affect the fit of the dentures, because the scan is going to be misrepresenting of the tissue. So if we can get everything as healed as possible, then the scan will be more accurate, and the final or the immediate denture will fit better and be more retentive for longer. Always with the disable AI cleanup. As I mentioned before, I only use iTero because that's what we have in the clinic. That's what we've always used. And then on the upper, I capture the palate, the maxillary tuberosities, the vestibule, and all remaining teeth. And on the lower retromolar pad, the lingual and buccal vestibule and all remaining teeth. So just kind of like what we've talked about with the partial and everything, just capture as much as you possibly can with the scan. And drying the tissues, also super important, because then it will be captured easier. So the advantages of scanning. Just reading my notes here, but yeah, so no tray lock on. So I've never had that happen, but I remember in dental school it happening, and it was like chaos on the clinic floor, because it was like somebody's locked their tray on their patient, and it was like, I never want that to happen to me. And like I said, it's never have, look on wood, hopefully never will. But you don't need to worry about blocking out undercuts. You don't need to worry about, I remember in dental school, I put ortho wax between the teeth to help prevent them from coming out in the impression if they're super mobile. You don't need to worry about any of that, because the scan will capture what's there. And if the teeth are mobile, you won't know from the scan, and you're not going to accidentally pull them out scanning. And then it's more accurate representation of the tissues than with the PBS impressions. Like I said, if you're trying to navigate the teeth, you're doing closed tray impression, open tray impression. All these different techniques are fantastic, but you can introduce error in multiple ways. So they're already really, we already know immediate dentures aren't going to fit well in the end. So the best you can do to help alleviate all these other errors by just scanning is better for the patient in the end, in my opinion. And it cuts down on the adjustment appointments. Like, it's insane. I scheduled the 24-hour, schedule the 1 week, and then I honestly open it up to every patient. I say, if you need anything, please do not hesitate, come back, see us, we can adjust it. Often it's a little adjustment compared to what you'd be experiencing for pain. So just come back. And rarely they come back. Oftentimes so then we schedule the 3-month reline. And at that time, patients come back and the denture's loose, but there's no sore spots. They haven't had it. There's no issues with needing to do tissue conditioner or anything like that, because it hasn't been rubbing and causing ulceration. So the scan is simplified it so much for me. I can't like stress it enough, because it's the volume I do probably 4 to 5 immediate dentures a week. And the reason I can do that is because of the scan, because I'm not bombarded with adjustment appointments. So to maintain verticals, so yeah, if you have a stable bite, so like this patient, we just go with her bite. She's used to it, it's comfortable for her. So this is how we scan. We just scan her bite, get the denture to replicate this, knowing that we're going to need to reestablish it once she's healed because of the bone loss and everything. And one thing, and I've said this before, but I can't stress it enough, something that I've learned with dentures is don't try and reinvent the wheel, or it's like basically just keep it as close to what they're used to as possible and you'll have better success. So like, don't try and find the CR, put them in this perfect bite with an immediate denture, because if they go from their natural teeth to this new bite, all of a sudden it's just going to be that much more to have to get used to. So that's the beauty with the scan, is that you scan, the lab creates the denture based off of that, and it's most natural transition for them. And then once they've healed for 3 months and or become used to the denture, then you can adjust it and get them into whatever position you want. But I used to try all that stuff, get them in CR, get all these different things, and try and create this like ideal denture like we're taught in dental school. And at the end of the day, I was adjusting it for days because the patient's not used to it and they're having a hard time getting used to it. So keeping the transition for dentures, even if you're doing a new denture based off their old one using Simplest, same thing, just keep it as close as possible for the greatest success. That's been my experience. So patients who don't have a stable bite, but if they have partial dentures, what I'll do is I'll take 2 scans. I'll take the first scan, normal, like what I would take for an immediate denture. So without their partials in, all the tissues capturing everything. And then the second scan, and I make a note on this first scan that a second scan is coming. And then the second scan we take with their partials in. So like this patient here, obviously his bite, he's not a rabbit, he's not biting end to end like that. But sometimes people take the funniest pictures, and one day I want to have a collage of like me telling patients to smile and what they give me. But anyways, it's always fun. And so then the second scan with their partials in, we send for as the bite reg. So then we're still able to keep it to that 1 appointment scan and get the dentures made, and then going right into the delivery. So this guys we delivered on Tuesday in Kindersley, and it was fantastic. I couldn't be happier. I forget to constantly take pictures and videos, so I apologize. But yeah, he was biting canine to posterior, and then also with his partial, we kept the teeth similar, so that with his new denture, people are like, "Oh, we got new teeth," which is one thing I never want people to say, unless the patient wants that. But always keep it as natural as possible. Otherwise, if they don't have partials, I do use wax rims. So I'll scan everything. I'll get wax rims made, and then we do wax rims the traditional way, and then take a bite registration, send the wax rims back. Still, I don't use I don't take a final impression. I just use the wax rims and then the scan for the dentures. And then if the patient has worn out teeth too, but like a stable bite, they're just like so worn out, I'll ask the lab to increase it, whatever the case may be, 2 millimeters, 4 millimeters. and then we go from that. Again, I don't really get too fussy at the immediate stage because it's going to change anyways. So this is what I've been doing to change the vertical. This lady, we also wanted to add lip support. So I use putty and I place it in the denture. If it's just the bite, I'll make like a horseshoe and get the patient to bite on it. And then we just kind of tweak the putty and alter that. This lady, like I said, we wanted added lip support. So with her trying in, I added the putty until we had the proper lip support that she was happy with. And then I just send the putty into the lab as a reference. And this is something I just started doing. And so far it's going well. Yeah, I'm always trying to think of ways to cut down on the appointments, because when patients drive an hour plus to see you and at the cost of gas, they actually get so irritated if they have to come back. So but he's been working for me to increase the vertical after they've had their immediate. So this is the most basic of what I send for pictures, and I started sending these pictures because I was having some issues, and I'll show a case of that later. But so this lady here wanted immediate dentures, so I send a smiling picture, a closed mouth, and then usually we use cheek protractors now. This was a while ago, and obviously just use my hands. But honestly, the lab was able to use these pictures and create a beautiful denture for her. So, excuse me. And then as far as shade goes, I always go a little bit whiter than their natural teeth. Everybody wants to have the white, like if they've had a smile like this for years, they can't wait to have a beautiful smile. And so I always go a little bit whiter than their natural teeth. If we're keeping any teeth for a partial or anything like that, I try and keep as true to as possible to those teeth that remain. And then I go with the whites of their eyes as a good reference as well. I read that somewhere and I can't remember where, but it seemed to work. And I never show them the whitest shades, of course, everybody know that. So and then I always get their feedback. And so I've also had the odd patient where it's like their teeth, if they're really worn down or decayed, I get them to send in a picture of what they looked like before, like back in the day, a grad picture, wedding picture, whatever. And then I send that to the lab. So that's what I send for my immediates, the scan and then pictures and then just written instructions, generally keeping the size and shape of the teeth or increasing them if they've been worn down, a shade, and then make a request for the dentry process. So like I said, about 80% of the time it works out great, and the patient's really happy. So staging treatment, mentioned this before, I'm a huge advocate, love doing the posterior extractions first, letting that area heal, especially those molars. Sometimes you just never know how those molar extractions are going to go, and keeping the buccal bone, of course, can't stress that enough. So important. Keeping the maxillary tuberosity, so important to the good fit of the final denture. Again, Neki, I should have put it in here, but Neki Jamal's course is the best I've had for extractions, really changed my game. And that's the so yeah, I do the posterior teeth generally up to the 4s, keeping the premolars at least 2 contacting premolars for that established vertical, and then generally wait 6 to 8 weeks. I never wait 12 before proceeding unless the patient, like, unless there's issues or whatever. And then yeah, once they've healed, then we get the scan, and then a hygiene appointment before the scan if necessary, get rid of bulk debridement. And then once we have the scan, take pictures, and then delivery extraction of remaining teeth. I do a 24-hour recall. Now that I know about the canines and the freedom, I look for that at delivery. And if it's blanching at the tissues, then I'll adjust it until it's not. I'm trying I like the 24-hour recall, but when I work in Kindersley, I'm only there on Tuesdays, so we only do a 1-week recall. I invite patients to come to Rosetown if they need anything, but they rarely, if ever, do. So there we do a 1-week recall, and we've had good success with that. Patients are still functioning, wearing them, eating, that type of thing. So again, I attribute it to the scans and not having anything overextended or crazy going on. So this is how we price our dentures. So we have the professional fee, the lab fee for the immediate, the lab fee for the simplest, and then the total cost. So I've built in the cost of the simplest denture reline at the end. And the reason for that is I used to do the cost of the immediate with the lab, and then I would charge for the reline, and then patients would be upset because they're like, I just paid for this denture and it doesn't fit. And I'm like, well, there's a lab fee for that reline and I'm not paying for it. So anyways, what we switched to last year, we included the traditional reline fee. I think it's $250 into the cost of the denture. And then this year, in my ever-growing attempt to get more digital, we switched and increased it by $500 to include the cost of the simplest denture. So at that 3-month reline, we reline the denture, scan the denture, and then have a new one made. So they'll still have their old immediate denture as a backup, but then they'll have the new simplest, and then they don't have to go without their teeth, because right now where I'm in Rosetown, Kindersley, rural, it's about a 4 to 5 day turnaround. So I'd get patients in Monday morning, and then we'd try and get their denture back. Usually it would come back Friday. We'd try for Thursday, but we get it back Friday. So yeah, so now they're without their teeth, which when masks were in fashion, everybody was okay with it because they're like, oh, I'll just wear my mask. But now nobody wants to wear a mask, which is fantastic. So I've just built it into the cost, and I actually haven't had any issues. So that's been since January. And I explained to patients the increased cost is so they don't have to go without their dentures, and they get a second one at the end that will fit a lot better. And a lot of patients have been happy with that. So I think it's been working good. And like I said, having it all built in at the upfront cost saves that discussion of patients being irritated that they owe more money. And then when they get their final one, it feels like a free one because they've already paid for it. They don't have to think about it. So okay, the setting patient expectations so big. I can't stress this enough. So at the consult, I always stress, because a lot of people can't wait to get rid of their teeth. And so I stress to them that it's a prosthetic. It's like cutting their hand off and then having to give them a prosthetic. They need to learn to write, shake hands again, eat, hold a fork, all that stuff. So I'm like, it's the same with their teeth. They're going to need to learn how to talk again, how to smile, how to laugh, all those types of things. So there is a learning curve, and no matter how excited somebody is, I'm always real with them about that, because I've been burned where I get excited with them and say it's going to be fantastic, and then the reality of the delivery happens and it's never good. So always stress it's a huge transition. Always go through what to expect. So the 24-hour checkup, the 1 week, how the denture is going to get loose because they're healing, and then yeah, so that's the consult. I'm very real. And I say, you're going to walk in with your teeth and you're going to walk out with 2 hockey pucks in your mouth. And it's going to be a huge adjustment, but you will get used to it. And I always stress to them that we do it a lot. I've done it a lot, and I'm here to support them. And I find that that reassurance is a lot for patients, because it is a huge transition. And I can't even imagine how scary it was. I had a dream once that someone pulled my teeth and gave me an immediate denture, and I woke up in a cold sweat. Like, oh, so, and then at delivery, I go over it again. I go over that, we're going to extract their teeth. We're going to place the denture. It's going to feel like a mouthful. I'll see them in 24 hours. Don't take it out. If it comes out, put it back in right away. And I remind them that it's a Band-Aid. I'm like, think of it like a Band-Aid, because if you're not happy with the smile, if you're not happy with the smile, we can change it. If you are happy with the smile, it can change and be very different come 3 months. And even in a year, once you're healed, that at that point we can really dial it in. But I'm like, think of it like a Band-Aid. we have a lot of guesswork that goes into it. I'm always like, there's a lot of guesswork from the lab because you still have your teeth, you can't try it in. But at the end of the day, we'll make sure that we have something you are happy to wear. And again, if they have periodontal disease, whatever the situation may be, I go over how it's going to be loose. I say it's going to be like a hot dog down a hallway. It's going to be so loose, and then we do the reline and it'll tighten it up. And then at the point for our post-op check, I ask how their night was. I ask if they've been eating. I had a very long journey to dental school, which included 2 years in the College of Nutrition at the U of S. And so I've had my first 2 years of dietetics. So I'm very passionate about food and making sure patients get the proper nutrients. So I always talk about eating foods that have sauces in them, gravies, something that makes it easier to swallow, so that if you can cut up into small pieces, chew it as soft as you can, and then you have the sauce, it's easier to swallow. My goal and hope and dream is to come up with a recipe book for denture patients, immediate patients, but I need to take some serious time off to do that, which I'm not willing to do. So I always just talk about soups, stews, chilies, very fine minced, very easy to chew, very easy to swallow, and then always emphasize protein and vegetables, because again, when I first started doing this, people were coming back eating Katie and mashed potatoes and gravy for weeks, and they literally were starting to look gray, and it was like, oh no, like you can't eat like this, you need to start eating properly. And the reality is that our North American diet has a lot of soft foods, so there's no way I'm getting through this whole lecture today, sorry. I'm just so passionate about this stuff, but we'll just continue next week. The reline one, I don't know, have much to say about that, so whatever we don't get through today, I'll finish next time. But so yeah, that's super important. Also at delivery, as far as pain management goes, my wife's a pharmacist, so she has me on a strict naproxen 500 milligram diet. So I do naproxen 500 milligrams twice a day, and then for 7 days, or PRN, depending on the case. And also depending if there's a lot of infection, a lot of pus coming out, that type of thing, exudate. When we do the extractions, I'll put them on an antibiotic. I've done both, where I do and I don't. And at the end of the day, unfortunately, putting them on an antibiotic does help with the healing a lot, obviously. So we do that. I used to do chlorhexidine rinse. I don't anymore. I just encourage salt water after a few days. So again, there's their post-operative instruction sheet, which goes over everything I just talked about. So patients have a written form. Again, we just introduced this recently. My denture program is just constantly in the works and evolving. So I'm looking forward to the day where it's really dialed in. But yeah, this is something new, but it's really good because I have had patients call and they're like, what am I supposed to do within the first 24 hours? And I talk about it at every appointment, and at every appointment, it's brand new information. So fair enough. I talked to an electrician once and I had no idea what was going on, so I had to get my dad to do it. Product placement, always my favorites when it comes to dentures. The indelible stick is going to be your best friend, especially for the first week, because of PAP paste, you don't want to use that with the open sockets. You don't want it to be a growth medium for bacteria and then source of infection. So I use indelible sticks to mark any sore spots, and then we go from there. And then PIP remover and the tray adhesive, and then the yellow sticks in the back is just what I use when we're doing the reline and border molding. Okay, so we're going to go through some cases here. So first one here is Boyd. So immediate dentures. So there's his pan, there's his before pictures. Like I said, we started introducing cheek retractors, so that is a fantastic thing. So this is his treatment plan. So extracted the posterior teeth, let him heal for 6 weeks. He had one filling to do, hygiene appointment, and then we scanned for the lower partials. And then at delivery, we extracted the remaining teeth and then delivered the complete upper denture and then the lower partial as an immediate. I used to do this a lot more. Now I'm really trying to get away from doing any sort of partial as an immediate because of how much it changes, especially in the anterior. What I have done is do like a Valplast, like a very, like just the simplest acrylic denture, again, build it into the price. And then they wear that while they heal. And then once they're fully healed, scan and do a cast partial. Because again, the reality is that it's just, I did one the other day and it was like, you extract the teeth, you place the denture and it's already rocking because it's not sitting on the gum. So it's like, now this is going to be a source of pain for him, irritation, and adjustments back in my chair. So yeah, that's what I'm trying to get away from. It's a hard sell. People don't want to be without their front teeth, which is fair enough. I wouldn't want to either. So this is Boyd's scans. One day I will figure out how technology works, but right now I just film on my phone and then upload the video from my phone onto the computer, into the PowerPoint. So that's what the scans look like when we send them off. This one I didn't realize it's upside down there. So yeah, so getting all the vestibule, getting as far back as possible, and sending that to the lab with those pictures that I showed earlier. So that's scanned with these pictures here and a few more. And then that's just post-op 24-hour smile. So he wanted to keep the diastema. He wanted to keep that space between his two front teeth, characteristic to him, which I'm always so excited about because I think it's a really natural transition from dentition to dentures, and it looks so good. Again, his eyes are closed. And so this is what I'm talking about in the canine. So you can see I've marked it with indelible stick, and they're little white ulcerations, and they're the smallest little thing you need to adjust. The other thing I will say is when I first get a denture, before inserting into the patient's mouth, I'll just rub my fingers along it and just feel. Sometimes there's the odd little blip in the material, and just take it, adjust it out before you even put it in the patient's mouth, because guaranteed they're going to be coming back saying that there's this irritation to them. So we will take care of that at that appointment. So it's always a little frustrating when it comes out of the mouth because the indelible stick does spread, but it gives you an idea of where to adjust. And then even if you feel there, oftentimes you can feel if there's a point that's higher or sharp, and then adjust that. And then yeah, I could sometimes cheat and just put a little PIP just at the very ridge if I'm not finding it and using the indelible stick. The patient's like, nope, still there, still there, still there. I just cheat a little, but then I'd be sure to clean it off and everything like that. So this is his 3-month reline. We're actually delivering the reline tomorrow. I was hoping it would be coming in so that we could show an after picture, but that's what the healing looks like at 3 months. And then again, we had to reline the lower partial because at the very bottom there, it was not fitting good. So again, always looking for a really nice roll over the border. And I do like to see some burn through because it needs to contact the tissue somewhere. I find if you don't have that burn through, if it's all just solid, you've extended it, whether you meant to or not. So having some areas, obviously the denture should contact somewhere, especially like I said, in that back where those teeth have been gone for a while. So yeah, and then we send that in. So we'd scan that reline, key social assistance. So unfortunately it has to be a different way. So we send the denture in. So this is Patty. So we've seen her picture a few times. So she ended up having, oh my gosh, a cyst left over after the extractions. I'm blanking on the name. But so anyway, she had some time with the oral surgeons and back and forth. So we actually had a pretty big delay, about 8 months between the posterior extractions and the rest of her case. So when she did come back to us, all we had to do was scan for the immediate denture, extract the remaining teeth, and then do our recalls. So this is her at 24 hours later. It's insane. Like when you look back at this picture, it looks like an older lady. And then you go to this one and she looks so much healthier. And that's the reality is there's so many times where a lot of these teeth have massive abscesses, infection, decay, their body's just constantly fighting. And once that's gone, their skin looks better, their face brightens up, and they're just like a huge transformation. They become this whole new person, healthier person. So it's fantastic and so exciting to see that. So that's what her sockets look like. Again, you can see there's some rubbing there up in the canines. I tried marking it to see in the picture. Okay, so this is Nathan. So this guy, again, he was supposed to come today, and I thought we'd have a fresh off the press reveal, but he no-showed his appointment, so we don't have a reveal. But anyways, this is what his case looks like. And so you can kind of see at the bottom the denture there, the upper denture. And oh, if I extend this, sorry, didn't realize I had the whole screen. So the bottom denture, you can see the one side kind of dips in. So the extractions there were done previously, and a lot of the buccal bone was removed during the extraction to get at the 2.6. So he's left with almost an indent there. And then on the other side, all the extractions were a lot better. So just the fit of the denture on that side for him is just really compromised because there's no ridge. It's just flat and then a little bit of a tuberosity. So luckily he has the rest, but at the end of the day, it really is gonna, at the end of the day, that's how he's gonna have to live for the rest of his life. And I always think of that when I extract teeth and do dentures. So this is border molding movements. I just gently hold the denture in place, do these border molding movements. And then if the denture is dislodged, I know it's overextended, and then I adjust it. But again, I don't really have that issue with scanning. I had it way more with the traditional dentures. And I still do that with the PIP paste. And then all these are marking the burn through areas. So that's what I'll adjust. And then quick video of me adjusting. So try and keep it limited to that area. And then we'll go from there. But I would really want to get to some of these. So this was, so when we delivered his denture, and I don't have a picture, but he had a posterior open bite, I guess, like, so only his back teeth, so I ground it in, and so you'd have a decent bite. And then when I got the reline back, I asked for them to close the open bite, but I didn't specify to intrude the posteriors and not extrude the anteriors. So what they ended up doing is keeping the back and then just extending the front. So then this was him at rest. It's just like all teeth. He looks like a jack-o'-lantern. And so then all I did, and like I said, I haven't got it back to see how it worked out, but I just marked the inside the lip line with Sharpie. And so this is a work in progress, a little bit of an experiment to see how that goes, but that's what I've done in the past. Okay, I'll do this case and then I'll save the rest for next time. But so this was Arnie. So this was before I took pictures. And so this is highlighting the importance of taking pictures, because since doing that, like think back to Patty's case, how it was so good. Think back to Boyd's case, same thing, really nice. So before I took pictures, I would just send the scan and not even like ask for the dentures to be extended or anything. And then it comes back and there's a denture in there, but you can't tell. And the patient was quite disheartened because he was looking forward to his new teeth. So this is what his denture looked like. So on the top, it looked like a pediatric denture, like it looked so small and tiny, but that's what his teeth were. So then we relined it, sent it back, and had larger teeth put in. And so that's what he looked like a month after. We waited until the sockets healed. And then he came back, and again, it had shrunk because he'd healed up more, so you see even less teeth. So then we do the reline, light body PBS, slow set is my favorite. And then this was his final denture there on the bottom. And this is a nice picture because it shows, like, so that's the reline, that's what we sent, scanned. And then on the other side is the PIP paste. And you can see that there's intimate contact with the tissues everywhere. So with PIP paste, if there's brush lines, it's not touching anything. If it's burned through, it's touching too hard. So few areas to adjust. The rugae, I find, especially on these digital dentures, is always so prominent. So it'll burn through like that. So I just hit it really lightly with the adjustment burr, and then that helps it a lot. So there's Arnie's final smile. And I'm just gonna see, and yeah, so the rest is just cases. I'm just seeing if there's anything else. I'll go through this one really quick. So this is Karen. So this was one where we did the 2 scans. So we did the scan with her partials in. And that again, established vertical. And then one with her partials out. And that. Is what the scan looks like. And then that's how she kept smiling, just like her lower teeth. So I tried helping her with holding my fingers where her teeth are. Now she knows how to smile, and she's really adjusted well, but this was 24 hours later. And so yeah, really sweet lady. And then this is just something really cool. This young girl has had a denture for several years, and smaller teeth, so she wanted bigger teeth, and she wanted a diamond put in. So it was so exciting. So that's what we did with the simplest system. Scanned her denture, asked the lab to put a diamond in, and she's rocking it. She loves it. It looks so good on her. So I love the characterization and special things you can do with dentures that really make people really happy. So I got through everything except one case, which is also still in the works. So it's not the end of the world. Hopefully by the next webinar, it will be done, and then I can discuss it then. But otherwise, thank you guys so much. And we'll see you June 7th. And June 4th is my birthday. So I'll be fresh from turning 34.
Oh, awesome. Thank you so much, Dr. Bertsch. I thought that was a great job of being extremely informative on the process behind the immediate denture. I also loved how you emphasized how beyond just bringing in that new revenue stream and being profitable for your practice, how much this immediate denture process can actually transform the lives of your patients. And at the end of the day, that's really what it's all about.
Yeah, it's so exciting.
All right, well, we'll open it up for a little question and answer. Feel free to put any questions you do have into the box there. Another thing that I was really happy to see on there is encouraging people to put in photos of the teeth beforehand. If they have any severe decay or anything like that, sometimes it can be difficult to know what they're looking for. And like you said, a diastema, things like that. It's something that as a lab, we can put into our design very easily. And even though we don't have the possibility on immediate to do the try-in denture, we can still send an STL file and have you look at the design. If the patient wants to be a part of that process, they can approve it or not. Or if you just want to see what it's going to look like, feel free for that as well.
Yeah, that's so true.
All right, so we got a few questions rolling in here from Dr. Riahi. What are the special instructions for after delivering the immediate denture?
So the first 24 hours, I tell the patient to keep the denture and do not take it out. I tell them I'll be the first one to put it in. I'll be the first one to take it out. And then after that, so the first week, and like I said, I have that 1 week recall. So I tell them wear it 24 hours a day. But after that first 24 hours, I want them taking it out every time they eat something, and before and after bed, rinsing the denture and rinsing their mouth out gently with salt water. I emphasize I don't want anything being caught underneath that could cause infection, fester in the socket, that type of thing. So I always get them taking out every time they even drink something. I encourage them to take it out and just rinse it for that first week. And then at that 1 week recall, I evaluate what their sockets are like. Some people heal incredibly well, some people are less. So, and then I give them instructions on whether they can continue that. But generally at that 1 week, then we transition them to just daytime wear and then taking their dentures out night and using the Polident overnight tablets is what I recommend. And soaking the denture in that. So first week, after that first week, they're taking it out, and then I really want them getting in the habit of not wearing their denture at night. So that's their instructions. Use special acrylic Bertsch adjustments. Material is harder. It's a adjustment kit that we got from Henry Schein, and it has a polishing burrs on it and then adjustment kit, and I really like it. It's really soft and does a really nice job of keeping everything smooth. I can include that in the next webinar or send it to you, Daniel, and then you can hand it out. But yeah, there's a specific block that I have at Kindersley and Rosetown I've been using for about 4 years that I really like, and I'm sure you can get it from any supplier. Indications for simplest denture. So simplest denture in the context of an immediate denture is at the reline stage. So once the teeth have been extracted, they've healed up for 3 months, you've done the reline, and then I scan the denture. So the patient gets to keep their immediate denture for another week, and then they get their new simplest denture, the digital one. Otherwise, other indications, denture fits good, but the teeth are worn out. Patient needs a reline. And then instead of doing the reline, we do the new denture, patient's denture. The other day, somebody came in, there's a crack down the middle of their denture, but it's still together. You can just see the crack, and one day it's going to go. Excellent use of simplest. We did the reline scanned. And so yeah, anytime that you have an existing denture, you can use it, do the reline, and then use simplest. So
excellent. Don't see another question on there. So if that is all from people, what I will do now is just ask Dr. Bertsch if I can get you to stop sharing your screen, and then I will share mine. We'll put up a quick QR code where people can find a way to sign up for our next webinar, as well as other webinars on the Orem website. We have one coming up later next week for practice management, if anyone is interested in that one as well. All right, so people can see my screen there. I'll leave that on for a little bit. All right.
I've never actually claimed the CE for doing these.
Oh, you should definitely get on that. And I will also say that as well. For this round, we're just going to use the emails that are used for the Zoom call for the CE credits. They'll be sent to you. If you are looking to have it sent to a different email, please contact Tanya S@oremgroup.com, and we'll make sure we get it to that email address as well. All right, so if there's no other questions, we can definitely let everyone go on with their evenings. And I'd like to thank you for coming out to see round 3. Hope everyone comes out to round 4 of the series. And again, a big thank you to Dr. Bertsch for a great job, and we're looking forward to see the next one.
Thank you so much.
All right, thank you.
Bye.
Bye.